Just go. Hi, good evening, everyone. I'd like to welcome you, a friend who I hardly see, even though we work in the same hospital, in Sunway Hospital, and I almost never see her because she's always so busy. She's our geriatrician in Sunway, and she also is trying to complete her PhD in dementia in 4 years while working full-time. I'm just amazed at this woman. Anyway, the story is I met Dr. Tay not in Malaysia. I met her in Mongolia. We went for a trip together and we spent almost 3 weeks together on a road trip. It was really, really an interesting, fantastic trip that we had. Oh, I look back, I want to go back again. And we took a lot of photos. That was the trip that we learned how to pose for photos. It was quite interesting. But today, we're not talking about Mongolia or me or our trip. We're going to concentrate on the treatment or the management of dementia. And as our population grows, of course, this would be a very, very important topic for all. Not just not just doctors, primary physicians and GPs, but also family members and caregivers. Okay, Fernand, go ahead.
Okay, thank you, Betty, for the introductions. So good afternoon, good evening, everyone. I'm Dr. Tay, I'm a geriatrician. So today I'm going to share with you management of dementia at primary care. Can you see my slide?
Yes, we can see your slide.
Okay. So I think I've got quite a lot of slides to show. So let us start.
Yeah, sure.
This is the outline of my presentation. Number 1 is getting the concept right first. Number 2 is overview of the diagnostic criteria. 3 is cognitive and non-cognitive assessments. Number 4, investigation. 5 is pharmaco and non-pharmaco management. Following by do and don'ts for a person with dementia, future management approach, and can we prevent dementia or not? Okay, so this presentation, I'm not going to throw you with all the numbers or evidence or what. I'm going to give you some practical tips and approach how to deal with person with dementia. So number 1, get the concept right first. So what is dementia? So I'm not going to give you the long detailed explanation or definitions. You need to understand it is a neurodegenerative conditions. Okay, and then it is usually multifactorial, and it is a chronic and progressive condition. So neurodegenerative disorder, it will affect the brain function. Our brain function, we got a lot. We got motor, sensory, our coordination and balance, cognitive and emotions. We got major 5 components of our neuro functions. So for dementia patients, usually they were started with cognition and also emotion disturbances. Then as the disease progresses, it will involve the sensory, the motor, and the balance. Yeah, so it's a progressive diseases. So dementia is an umbrella term. There are many, many diseases can lead to dementia. And Alzheimer's disease is the most common disease for elderly in dementia. It followed by vascular dementia, mixed dementia. Mixed dementia previously we referred to Alzheimer's disease and vascular dementia, but now we refer to multiple etiologies. Sometimes it can be more than 2, or vascular plus Lewy body, vascular plus frontotemporal, can mix dementia. Lewy body dementia, Parkinson's disease dementia, so on and so forth. The list very long. Yeah. As we've studied more about dementia, the more subtle dementia we find. Okay, so this is the general concept you need to know. Have you seen this CPG? Management of Dementia 3rd edition. This is the Malaysian CPG. We published in 2021 and then we launched it in 2022. Do you remember the launching by our ex-Minister of Health, KJ?
No.
Then the Pakla story came out. That's the launching ceremony for our CPG of dementia. Okay, so I'm one of the authors for this CPG. Okay, so what are the major changes for the new CPG? So number 1 is no more screening tool. It is called cognitive assessment tool. Previously, the previous CPG, they put the name screening tool. This is too confusing because the screening tool doesn't really serve the purpose of screening tool. Later, I'm going to explain to you why. the cutoff point can be too confusing and has potential bias in our populations, because we know all the cognitive assessment tool can be potentially educational bias. You cannot use the same tool to assess a retired professor and a makcik from the kampung who never received formal education. It is not fair. It has potential bias. Yeah. So later I explain more when I come to the cognitive assessment tool. So number 2, we introduce the DSM-5 diagnostic criteria. So number 3 is emphasis more on non-pharmacotherapy. 5 is introduce potential inappropriate prescription for person with dementia. So we know that dementia until treatment. So although we cannot treat much, but at least we do no harm. Don't give certain medicine that might cause their cognitive decline further. Yeah, so this is the important thing we add in the new CPG. And then last is driving assessment. Yeah, so we start with overview of diagnostic criteria. So let you get the concept right. What is the major change in diagnostic criteria so that in the assessment, history, and physical examination, you know what to do. Okay, this is the history or evolution of diagnostic criteria for dementia. First described in the DSM criteria in 1980. Then after that, it evolved and changed. The diagnostic criteria changed over years, and not much changes actually until 2013. We have the DSM-5, then there is a major change. So compare DSM-4 and DSM-5. DSM-4 previously we call it dementia. DSM-5 we call it major neurocognitive disorder, or in short form, NCD. Yeah. MCI is mild cognitive impairment. It is a pre-dementia state. So previously we call it MCI, it's quite a new concept. So now we call it mild neurocognitive disorder. But as long as you write dementia, MCI, or NCD, it is interchangeably, we understand. But if you read journals, sometimes you will encounter all this new terminology, then you should understand what they mean. Okay. So the diagnostic criteria, previously the cognitive domains, they mentioned about the 4A. The patient must have amnesia, memory issues, plus one of the A, anoxia, apraxia, or aphasia. But for the new criteria, they involve these 6 cognitive domains. You only need to have one, either one out of these 6. Then you can diagnose dementia already. Why we have these changes? Because we notice different subtypes of dementia, they have different presentations. For example, frontotemporal dementia, they might presented with social cognition issues. They have misbehavior. They have disinhibitions. Yeah, but if you test your memory, they are quite okay one. They might present a language issue. For example, one of the subtype of Alzheimer's disease, primary progressive aphasia, they have language issue first. A lot of neurologists, they misdiagnose as stroke with aphasia, but actually it's no stroke. You do an MRI, no stroke at all. So it's one of the subtype of dementia presented with language disability first. So that's why we want to include more and more. We want to overdiagnose dementia so that we don't miss anyone. So they change this one. Cognitive domains, these 6, complex attentions, learning and memory, executive function, perception motor, or previously we call it visual spatial, language, and social cognition, 6. Any one of it then is impaired, then you can diagnose dementia. Of course, you must exclude delirium. Yes?
What's executive function? What does that mean?
Executive function means planning and carry out. For
Oh,
example, cooking, you need very good executive function. You need to plan what you want to cook, what menu, what ingredient you need to buy. You need to wash first or you need to cut first. Yeah. Which one to put first, the salt first or the sugar first? Yeah, all this is planning and carrying out executive functions.
That one I don't have at all. Okay. Okay, but I'm not demented. Okay, you can
yeah. Okay. So number 1, you need to exclude delirium. If it is a chronic progress, then maybe it's dementia. If acute onset, you need to rule out delirium until proven otherwise. And you need to rule out other psychiatric illness like schizophrenia, depressions. Yeah. And it should affect your activity or daily living for dementia. MCI, it may not affect your activity, daily living, but you need some help already. Okay, let us see how's the difference between MCI and dementia. How we differentiate the stages of dementia. Previous CPG, they mentioned or differentiate the stages by the MMS. You will find that one is lousy diagnostic criteria for the stages. So now the latest CPG, And the latest DSM-5 criteria, they stage it according to the functional status. Functional status in their activity of daily living, ADL. So for ADL, we further divide into basic ADL, BADL. So basic ADL means self-care, going for bathing, changing clothes, going to toilet. All these are basic ADL. IADL is a higher level ADL. I means instrument. So the ADL that need the instrument, for example, cooking, driving, using handphone, managing their own medicines, managing their own medicines, all these are higher level of ADL. Yeah. So you look at these two components. If the patients have abnormal score in cognitive screening, in cognitive assessment too, they got memory issue or cognitive issue, you did the cognitive assessment, then they have abnormal score, then you look at the ADL. If both IADL and BADL not affected, or IADL, they might need some help, then it is MCI. So need some help, for example, they're going for shopping, they might need a list of the shopping list to remind them what to buy. It sounds like all of us, right? Yeah.
Yes.
Now I need a list, to-do list, so that I won't miss anything. Yeah. So like driving, you need a Waze to help you to drive.
Yes, definitely.
Yeah. Then for dementia, the IADL will be affected already. Yeah, maybe affected their cooking, or they cannot manage their own medicine. They forget whether they took their medicines or not. Yeah. So IADL affected, by the BADL, basic ADL is still independent. They still can self-care, bathing, changing clothes and everything. So this is mild stage of dementia. For moderate stage of dementia, the basic ADL will be partially affected already. So maybe they know how to go to toilet for pass urine and pass motion, but they don't know how to bathe. They need help in bathing and changing clothes. Yeah. So severe dementia means totally dependent. As easy as that. You just need to classify it according to the functional status of ADL. Okay. So next, this is the diagnostic criteria for the subtype of dementia. If you're interested, you can go and read the CPG. So we skip this one.
That's
So
easy.
next is your practical issues. So when you want to further assess whether this patient have dementia or not. So number one is presence or symptoms suggestive of dementia, or clinician suspicious of patient at risk, at increased risk of dementia. So what are the signs and symptoms of dementia? To make it easy, in the new CPG, we put this up, 10 warning signs of dementia. So what are 10 warning signs of dementia? This is also the WHO and Alzheimer's Disease International's recommendations. 10 warning signs of dementia. Number one, memory loss. Most of the time, is recent memory will be affected. So those things that happened recently, then they will cannot remember. Yeah. So they ask you, the typical symptom is repetitive. Ask you the same question again, or they tell you the same story again. Also, it sounds like me also.
I'm not like that. Okay.
So number two, difficulty in performing familiar tasks. So for example, a mother who is very good in cooking, one day you find out, how come my mom's cooking, the taste is changed? Yeah. So sometimes they forget they put salt already, then they put salt again and again.
I
So the
see.
change should be, yeah. So difficulty in perform familiar tasks. Those that used to do very well, now they have difficulty in doing it. Number three, problems with language. Either they difficult in express themselves, reading, understanding command, all this is involved in language. Number four is disorientated to time and place. So this one you always get from the news, or some elderly get lost, then put in the newspaper whose parents it is. Yeah. Yeah. So this is disorientation. And poor and decreased judgment. They don't know what is right and what is wrong. So a lot of elderly, they cannot con by those
Scammers.
yeah, scammers, yes. So they have poor judgment. Yeah.
No, recently our colleague also got scammed, 5,000 ringgit.
Oh my goodness.
Us over in the doctor's lounge, 5,000 ringgit. She was so upset.
Oh my goodness.
Yeah. So no, she was not demented.
Okay. Maybe I give another example. For example, elderly lady, she bought grocery from the market, then she don't know which one to put in the freezer, which one to put in the downstairs one. So the vegetables and the meat and the fish
I
she mixed up.
see.
Yeah, so poor judgment. Yeah.
Okay.
And then number 6 is problems in keeping tracks of things. So for example, this all of us, we have some experience of misplaced belongings. Hey, where's my phone? Hey, where's my key? Right? But when you sit down and you think, hey, just now I went to toilet, then I went to pantry. So you trace back your steps, then you can find your phone. Am I right? Yeah. So this is, you can keep tracks of the things. Yeah. So you are not dementia yet. So dementia people, they cannot keep tracks one. They cannot find their belongings, they will start to blame people. You steal my things, you steal my money. Yeah.
Oh, it's
Yeah.
very common for old people to say people steal their money.
So it's the one of the warning signs. One of the warning signs.
I
Misplaced
see.
belongings. Yeah. If let's say it happen very frequently and they cannot trace back, then this is, yeah. The problem with keeping track of things, another one is, for example, in the conversations, after you talking to them, they get lost, they don't know what you're talking about.
Okay.
Okay. So number 8 is changes in mood in behavior. So some change of personality or some change of some weird behavior, then it is a warning sign. And trouble in a visual spatial relationship. Yeah. So this is a visual spatial function. Visual spatial function very important, especially in driving. So you need to know when you need to press the brake so that you won't bump into others people. But yeah.
Yeah.
Okay. And then for example, crossing a drain, a longkang, you need to judge how wide is the longkang, then you need to cross it safely. So these are the visual spatial judgment. And number 10 is social withdrawal. Sometimes they have some insight and then they feel not confident to come up to socialize. Yeah, so they withdraw themselves. Okay, so these are the warning signs of dementia. Any one of these should go to the doctor for further assessment. So if you find your patient have one of the weird signs and symptoms of dementia, then you should do further assessment. So for example, for GPs, primary care, you see a lot of diabetic hypertension patients. Yeah, poor control, you suspect non-compliant, maybe is their memory issue. You should do a memory test. Yeah, this is my advice. Most of the time we encounter all this. Okay, so if you suspicious, they got warning sign, then you should do your history and physical examination. History, of course, you want to know acute or chronic. Acute, delirium, another story already. Chronic, then you assess A, B, C, D, E. Yeah. A is activity or daily living. The B is behavior, change of behavior. C is their cognitive status. D is drugs, any medicines that may cause the cognitive deteriorations. Later, I will share the slide with you. And E is changes in emotions. Physical examination, vision, hearing, these two will affect the cognitive function. So a lot of time they refer to me cognitive decline, but I check, there's a lot of earwax in the ear. Once we clear the earwax, the hearing better, actually is okay. When you reassess the cognitive test, it is normal. Yeah.
I see.
Yeah. So these are the common things that you need to check. And check any focal neurological deficit, sometimes stroke.
How long do
Involuntary
you
movement,
take to see one patient?
at least 1 hour.
Oh my God. No wonder you're so busy.
Yeah. Involuntary movement for those Parkinson disease or Lewy body dementia. Sometimes rapid progress dementia, they have another type of involuntary movement and severe risk factors. Yeah, all this you all know. So after you assess all this, next is cognitive assessment. Which cognitive assessment tool to use? This is the common questions and very confusing for everyone. So for the CPG, we analyze all the evidence. So actually there are many cognitive assessment tools available. So every test got its own advantage and limitation. There is no perfect or best test. Yeah, it depends on your preference. So systematic review shows that up to 74%, 3/4 of cognitive assessment to have educational bias. Okay, so in our population, Malaysian population is quite heterogeneous. Our elderly populations, about the study shows that about 13% of them, they have no formal educations. Compared to overseas, those advanced countries, their education level is almost 100% is secondary school and above. So that's why they can use the cognitive screening tool. We cannot. is not so accurate in our setting. Okay. So the diagnosis of dementia should not based on the score only. Yeah, should not based on the score only. So you should combine all, then the assessment score only to support your diagnosis, to let you know which component is affected according to the diagnostic criteria. Okay. So there are many cognitive assessment tools. I'm not sure you're familiar or not. So for primary care, because your setting is busy, need to see a lot of patients. You cannot do it like me, spend 1 hour for one patient. So you may need to use the short screening tool, for example, mini-cog. Mini-cog is just 3 things to remember. Ask a patient, do a clock drawing test, then recall the 3 things. Yes, very simple one. And then the AMTS, 10 questions one, also quite easy to be used. Yeah, so these 2 are the easiest one for the primary care. But of course, the sensitivity and specificity is not so good. If you are familiar with MMSE, it's better because it assesses more cognitive domains, assess up to 4 cognitive domains. For mini-cog and abbreviated mental tests, it assesses 2 cognitive domains only. Yeah, so other tests is more advanced one. Okay, and then the best accuracy of new cognitive assessment tool is the neuropsychiatry test. So that one need 1 hour to complete it. I also don't do it.
You do
I
all tests
refer to
during,
psychologists or neuropsychologists to do it. Yeah.
you do all these tests for all your patients, some of the tests for all the patients. You just don't see them clinically, but you do this mental assessment.
No. You have to see clinically.
Yeah.
Patient is suspicious, got symptoms. Then you do the physical examination history, then cognitive assessment. So the cognitive assessment is to help you to diagnose only. You cannot base on it totally. So sometimes the score normal doesn't mean the patient don't have dementia, because some patients have a higher level of baseline. When they decline, they still normal.
I see.
Huh.
Okay.
Okay. So for example, retired professors, they score 25 in MLSE. It can be normal or abnormal. Yeah. But sorry, they score 25 in MLSE means abnormal. But a makcik in kampung who never received education, a score 20 can be normal for her. It's different. Yeah. So you cannot diagnose based on the score alone. So in this new CPG, we say, don't preoccupy with the score. You need to look at the whole picture. So the cognitive assessment tool just to help you to find out which components is affected.
I see. Okay.
Okay, clear?
Clear.
So now move to non-cognitive assessment. If you have time, you can read the CPG, because every assessment we got the tool and the assessment score one. The form is very long. If you want to learn all of this, we need to have another half-day workshop. So we got functional status, behavioral assessment, emotion assessment, caregiver burdens assessment, all got scoring one. Okay, so just to let you know, so many things to do. So after you assess, so for GP, so you take history, physical examination, do the basic assessment tool, the cognitive assessment tool is enough. Then you do blood tests. Okay, so all these blood tests is to exclude those potential reversible causes for cognitive impairment. So full blood count, renal function, liver functions, calcium, B12, folate, thyroid functions, VTRL, and HIV if indicated. Patient high risk behavior, then you do this. Okay, and then do a brain imaging. EEG not necessary unless the patient got abnormal movement. Yeah, then you suspect some seizures or some other types of dementia. Only you do EEG. So, but brain imaging for me is a must. It's a must. A lot of time we found actually is a normal pressure hydrocephalus or subdural hemorrhage or brain tumor. These 3 are the common things. Yeah, they presented like a dementia symptoms, but actually they are not dementia. They are other conditions. We call it dementia mimicking conditions. So another one is can rule out by the blood test one. Thyroid, hypothyroid, B12 deficiency, folate deficiency, hypercalcemia, neurosyphilis, HIV-related dementia. Okay, so there are many things mimic dementia, but actually they are not. You need to exclude first before tell the patient you have dementia. Okay. Okay, now come to management. Pharmaco and non-pharmaco. So in this new CPG, we switch the attention to non-pharmaco management, because until now we don't have a curative treatment for dementia yet. So we want to maintain their quality of life as much as possible. So for non-pharmacological management, if you want to talk about it in detail, then we need 1.5 day workshop.
Betul. Hey,
Okay.
precise.
So
Cannot.
mainstay of management of dementia for non-pharmaco approach, number one is caregiver training. Yeah, so we need to train the caregiver how to deal with the behavioral issue, how to deal with the issue that they're asking the same question again and again. You also feel frustrated. Yeah, how to redirect their attentions to do other things so that they won't go into this cycle again and again. Yeah. So how to manage those aggressive behavior, agitations, throwing tantrums? How can you deal with all this behavior without medicines? Because we know all the medicine, antipsychotics will make the patient deteriorate even faster. Okay, so this one we need to train the caregiver. So for geriatrician, we will run the caregiver training workshop for our caregivers regularly. Okay, and then communication skill, how to talk to them, because they will have reduced ability to understand complex command. You need to talk to them in a very simple and short sentence so that they can understand what you talk. Person-centered care. So this is another concept. This is how to plan the activity and the care according to the person preference, because every person is different, especially elderly. A day 8 of life baby, everyone will behave almost the same. When they're hungry, they cry. When they poo, they cry. Yeah, they behave almost the same. But for 80 years old elderly, everyone behave differently because of their different educational background, cultural background, grown up, their preferences in food, preferences in the choice of treatment. Yeah, so it's different. So you have to individualize and tailor your care into this person-centered care idea. So this one is a big concept in management of person with dementia. So activity or engagement, engage them with more activity so that you can stimulate the brain. Okay, so don't let them alone in the house. So what I noticed in recent years, because of the COVID pandemic of the MCO, a lot of elderly, they are deprived from social activity. They have a lot of social isolations, and we notice the trend of dementia is increasing. Yeah, because of lack of these social stimulations. And so number 2 is structured non-pharmacotherapy. This one is usually done by therapists, occupational therapists. You should have trained. And then there are series of cognitive stimulation therapy planned and done by the occupational therapists. So they will assess the patient's ability. It can be individual or group activity. Then they will do the stimulation activity according to the person of dementia, according to their cognitive deficit. So it's a very specialized kind of plan and therapy. Okay. So the other type of non-pharmacotherapy which has evidence one is music therapy, art therapy, aromatherapy. All this has small evidence here and there. Okay. So anything the patients like, it is individualized. So individualized is the keyword for non-pharmacotherapy. Usually I tell the caregiver, you need to know the patients well, because this is your mom or your dad, you know them better than me. So I tell you the concept, how to stimulate them, then you go and plan the activity yourself. But don't trigger them, don't make them more frustrated. You must know what is their do and don't. Okay, so for pharmacological management, very easy for dementia, not much choices on medicines. Okay, so we divide into 2 major group of treatment. One is choline esterase inhibitor. One is NMDA antagonist. So choline esterase inhibitor, we got donepezil and rivastigmine. So these 2 is to stimulate so that you have more acetylcholine in your brain. Okay, so acetylcholine esterase inhibitor, you can use it in Alzheimer's disease, vascular dementia, Lewy body dementia, Parkinson disease dementia, but it's not working in frontotemporal dementia. For NMDA antagonist, we got only one, which is memantine, or the brand name is Alexa. Alzheimer's disease, you can use in moderate to severe stage, but for me, sometimes I use in mild cases also, especially when my patient have a lot of behavioral issues or they cannot tolerate the choline esterase inhibitor. Then you can use in vascular dementia, Lewy body dementia and other disease or dementia, memantine is not working. So only Alzheimer or vascular have evidence. So the treatment of choice is very limited. So that's why we put our stress on non-pharmacotherapy. So for those who you have confidence you want to start diagnose and start treatment yourself, can, no problem. So this is the dose usually I advise you how to start for donepezil oral. Now we have transdermal also, yeah, the patch one. You can, the starting dose is 5 milligram per day, escalate to 10 milligram every 2 to 3 months. Previously, the maximum dose is 10. Now got evidence to show that it can go up to 15. But my experience is for Asian people, because of smaller size, when go up to 15, majority of my patients, they have start to have nausea, vomiting, and giddiness. So the tolerance is not so good. So most of the time I maintain at 10 only. Okay. So the common side effect is giddiness, vomiting, anorexia, suppress the appetite. So be careful if your patient is those very skinny one, poor appetite one. You don't want them to lose weight anymore. Yeah. So must monitor their weight and appetite if you start donepezil. And then use with caution with patient beta blocker, because donepezil, it can cause bradycardia. So if let's say beta blocker plus this donepezil, it cause more bradycardia, the patient might fall. Okay, so be careful. So number 2 is rivastigmine. We got oral and transdermal preparations. For my experience, transdermal, the side effect is less because there is no peak. It is static one. The blood level is static one if you use a transdermal patch. So the similar side effect as donepezil. The starting dose for oral is 1.5 milligram BD. Escalate every 2 to 4 weeks until 6 milligram BD. This is the therapeutic dose. Transdermal, you can start with 4.6. Usually you put 5 milligram, and then escalate to 9.5 milligram daily. Then the higher dose is 13.3. And again, my experience with 13.3 is not well tolerated. Unless those big size patients, yes, they can tolerate. All those very skinny one, small size lady, most of them, they cannot tolerate. For memantine, starting dose is 5 milligram daily, escalate every 2 to 4 weeks until 20 milligram daily. So 20 milligram is a therapeutic effect. If the patient have renal impairment, creatinine clearance less than 30, maximum dose is 10 only. Common adverse reaction is actually giddiness or drowsiness. Yeah, they can be drowsy. So watch out for this drowsiness. Then rare but serious side effects, agranulocytosis, leukopenia, thrombocytopenia, pancytopenia. So far, I only encountered one patient have these side effects and not severe one. After I stop the medicine, then it come back to normal. Okay, so far so good.
Yeah, so
Next.
far so good. Those just now you said those 2 drugs are actually both the same group of drug, right?
Okay, you see, look at this slide. Donepezil, rivastigmine is same group.
Yes.
MMDA is different group.
Okay.
So for Alzheimer's disease, you can combine. So
Can combine.
combine.
Means you can use both drugs.
Yes. So initially for Alzheimer's disease, typical treatment pattern is we start with the donepezil or rivastigmine, either one first, either one from one group. Then you titrate up to maximum. Then if the patient still deteriorate, then you can add on memantine. Add on.
Aricept is which group? Is it one
Aricept is donepezil.
Oh, I see.
Aricept is the brand name.
Yes.
So the generic name is donepezil. Aricept is choline esterase inhibitor group. Rivastigmine is Exelon.
How does it work, this choline esterase inhibitor?
Okay. So in our brain, the neurotransmitter that responsible for this Alzheimer's disease or dementia is acetylcholine.
Oh, I see.
So it's a neurotransmitter. So choline esterase is the enzyme degrade the acetylcholine. So this drug is
receptors.
Yes, choline esterase inhibitor. So we inhibit the enzyme so that we have more acetylcholine in the brain. This is how it works.
So but obviously it works means by increasing the choline esterase.
Yes, but by inhibit the choline esterase, inhibit the enzyme so that your acetylcholine, your neurotransmitter will be higher.
Yes. So
then you think faster.
Okay, you think faster. So
yeah,
can a normal person use this to improve on their cognitive function?
No. So far the evidence shows there is no effect. For example, MCI patient, pre-dementia state patients, they even test this on pre-dementia state patients. Actually, it didn't show it will delay the progress to dementia.
I see.
Yeah. So for normal patients, I'm not sure whether it will help or not. For me, I don't think so lah. But I'm sure you will get side effects.
Oh,
Because all of us, we have normal certain level of choline esterase. We have normal level acetylcholine. So now you are giving extra, you know. So giving extra, then you will have side effects.
I see.
All these patients, they have not enough. They don't have enough acetylcholine in their brain. So that's why we let it have more so that they can function better.
Okay.
Okay. So far, no evidence to take it early.
Yes. I thought, well, if not, every day I use it. Okay.
Okay. So this is the nature disease progress for Alzheimer disease, the green line. So this is the MMSE score. This is, maybe I use the pointer. Okay. So this is the MMSE score. This is the years, over the years. So for Alzheimer disease, I talk about Alzheimer because this is the most common one. So it will progress gradually over 10 years from early stage independent up to total dependent until they pass away, about 10 years. Okay. So if let's say we give treatment, pharmaco or non-pharmacological therapy, so you will change the graph like this. But eventually it will deteriorate also. So it sounds quite sad, right?
Yes.
Yeah. So sometimes we need to educate the family members. Even with treatment, it will still progress. It doesn't mean that you are not doing good enough. You have tried your best already. You just need to accept it. Because a lot of family members, they will blame themselves. They are not doing enough for their parents, then that's why the parents deteriorate. Yeah, so they have a lot of guilt.
Oh,
So we need to educate the family members. This is the disease pattern.
okay. Can I ask you, on an average, what age does dementia comes in or Alzheimer's come in the elderly?
Okay, so if this question I answer you in a different prevalence in different age group.
Okay.
So for example, 60 and above, the prevalence is 1 in 10. 70 and above, 1 in 5. 80 and above, 1 in 4.
But
90 and
Well,
above, 1 in 3 or 1 in 2. It depends on different population, different country,
okay. So
different
now,
rate.
yes.
So
Now,
it increase with your age.
okay.
But as young as 40 years old, also some of these patients, they have dementia.
Okay. Now
Yeah.
I want to ask you again, but there was a slide where at the bottom there you say that dementia is not part and parcel of aging.
Yeah.
So why is the prevalence more higher in patients who are aged?
Okay. The concept is dementia is not a normal aging process.
Okay, it's not normal. That's the exact word you
Yes,
use.
that's the exact word. Dementia is not a normal aging process, but these disease happen more common in elderly. For
Oh,
example,
I see.
knee
Okay.
osteoarthritis,
Okay, I
more
get
common
it
in
now.
elderly.
So the concept of what we think dementia is wrong. So it's just like, if my LDL is this level, then it's lower. The risk of you getting heart disease is lower. If it's this range, then it's higher. So your LDL is now age. Okay, I get it now.
Yeah, age is one of the risk factors, and there are many more risk factors. All the cardiovascular risk factors are actually the dementia risk factors.
Oh, yes.
So if let's say you got a good heart, got good CV risk control, then your risk of dementia
So
will be
always
less.
must take statin. It's very important to take statin. I tell you, I take statin every day.
Okay.
Okay, go on.
Go on. So you understand this progress. With treatment, we delayed the progress. We are not doing miracle. So sometimes if the patient got side effects from your treatment and your medication, better stop it. Not worth the side effect actually.
Okay. Oh,
okay. So next you need to understand is not all disease progress like this. If they have an acute event, the patient has acute illness, it's very bad one, need admission one, the deterioration will become straight line. So for example, a person with dementia, they admit because of COVID pneumonia, quite a severe one until hypoxia need admission. So after admission, what happened? They'll become delirious, confused. So the cognitive function and functional status is totally dropped. after discharge, some of them might recover, but they might not recover to the baseline. They recover half only. After that, they continue to deteriorate. Yeah. So some of patients admit for hypoglycemia, blood sugar low, also it will deteriorate. Or they admit because of the acute pulmonary edema due to uncontrolled hypertension. Yeah, because they miss their medicines. Yeah, also it will drop. Any acute event, fall fractures, admission, surgeries, all this will cause acute deterioration in dementia. So the whole course of the disease, it will shorten already, and the deterioration will be very fast. So what we need to do is prevent all these acute events. So get the concept right. Yeah. So do and don't for person with dementia. Do, number one, is control the severe risk factors, because just now I mentioned all the severe risk factors: diabetic, high blood pressure, high cholesterol, obesity, smoking, all these are risk factors for dementia as well. But don't have too tight control of the blood sugar or the BP. Avoid hypoglycemia. And some of the patients, elderly patients, they actually has postural hypotension. If you read our latest CPG in hypertension, they got one section in elderly, postural hypotension.
Okay, I need to ask you about this postural hypotension, because I have this gentleman of mine who I've seen for 20 over years. He has hypertension and paroxysmal AF. And then recently he has been having postural hypertension, which is, I demonstrate even in my clinic. There's a drop of 15 or 20, like let's say
20,
yes.
30, yeah.
Okay, and then he's giddy, but now he knows how to handle it. He stands for a while, for a few seconds before he start walking. But I've reduced the blood pressure medication and kept the blood pressure now is about 140, 150. But he's still symptomatic. Today I put him on fludrocortisone. What is the treatment for it?
Okay, good questions, Betty. So postural hypertension is another big topic in geriatric medicine. Number one, we need to find out why postural hypertension. In elderly, most of the time is inadequate fluid intake. Some of them, they have urinary incontinence. They're so scared to go to toilet, so they drink less. So not enough water then can cause.
Yeah, I didn't ask that part.
Yeah,
Okay.
yeah. So adequate fluid intake. So number two, sometimes we call it adrenal insufficiency, especially those taking steroids one. Some of them, they're taking traditional Chinese medicine and all this.
Okay.
So they may have adrenal insufficiency, not the Addisonian crisis yet, but it's not enough already. So they will manifest this a little bit of symptoms of postural hypotension. Yeah, sometimes a cortisol level will tell you the answer. So number three, this is an aging process, or because of degenerative of the baroreceptor, all this.
I thought it was a sympathetic. I mean, this you know, something to do with his
with the sympathetic pathway. Yes, the degeneration of the host, the circulation homeostatic, to maintain the blood pressure. So usually the simple advice is A, B, C. A is iron, adequate water.
Iron. So everybody is Malay speaking. Okay, good. Okay.
B is the bed position. Sometimes when they sleep, we ask them to tilt the head a bit. Yeah. So this one is about the baroreceptor things. Number three is the calf exercise. Before they stand up, ask them to, especially after prolonged sitting or sleeping or sitting, when they want to stand up, exercise their calf exercise. Move your ankle up and down. Dorsiflex, plantarflex, calf exercise for 20 times, then only they stand up. It will settle the problem.
Oh, I see. Okay.
To pump the blood up before they stand up.
Okay.
These are the simple tips for my patient with postural hypertension to prevent them from symptomatic and fall. Okay.
Yeah. Okay. I learned something new. So,
okay, we go back to the slide. Number two is regular vaccinations for influenza and pneumococcal. Please encourage all your elderly, especially person with dementia, to vaccinate. Flu vaccine yearly. Pneumococcal vaccine, now we have a new one, just once for lifetime, the Prevena. Yeah, just check them. Okay, then to prevent them from getting admission for the pneumonia. And optimize the hydration and the nutrition, of course, and then treat the constipation. Constipation itself can cause delirious and can cause agitations. Sometimes they constipate, they don't know how to tell, then they'll start to behave very abnormally, very restless, agitated.
You're so animated. Okay.
Okay. So optimize the vision and the hearing so that they can get enough stimulation for their cognition. So other don'ts, avoid the anticholinergic drugs. After that, I'll have another slide. So complicated drugs dosing regime. So those TDS one, we try to simplify it to become the daily dose. Yeah. Okay, so this is another new topic we introduced in the new CPG, PIP, potentially inappropriate prescription, or sometimes we call it polypharmacies, but the more appropriate term to use is potentially inappropriate prescription. There are many guidelines for the PIP. Beer's guideline, the US guideline is the famous one. Another one is start and stop criteria from the European and British guideline. Yeah, so these two are the famous guidelines. But to avoid you from reading all the lengthy guidelines, you can just download this app is good enough. ACB calculator. You can search, ACB calculator. So you just key in, for example, here, I key in Piriton. Then it will come up with the score, 3. Score 3 is high risk for cognitive impairment.
Oh, I see.
So the drugs you can score 0 to 1. If didn't appear, means 0. It appear 1 means more mild risk, 2 is moderate risk, 3 is high risk.
These are risks to
cause cognitive impairment, the cholinergic burden.
Oh, I see. So I can use this ACB also lah.
Yes. So
Yes.
every time you want to prescribe for elderly, especially person with dementia, you check first what is their cholinergic burden. So the common things, common drugs with high anticholinergic burden that can cause confusion in elderly and person with dementia, I list out. Number 1 is the first generation antihistamine, means your Piriton, your chlorpheniramine, hydroxyzine, those antihistamine for the skin itchiness one. Even your Benadryl cough syrup also score 3. Yeah, so be careful. So you don't give Piriton, you can give loratadine for your running nose. So for itchiness, please give loratadine. The score is less.
I can't find this score, this in my app.
You can Google search it.
Oh, I see. Okay, maybe it's not an app. It's
not an app, it's a website. It's a
okay.
website.
Okay.
So antispasmodic, your atropine, your hyoscines. So sometimes patient diarrhea, you give loperamide. So it is very high anticholinergic, hyoscine. Short-term use may be okay, but not long-term use. Antipsychotics, all the antipsychotics, and tricyclic antidepressant, especially amitriptyline, quite commonly used in primary care. Yeah. Sometimes patient cannot sleep, you give amitriptyline. Neuropathic pain, you give amitriptyline.
Oh yeah, it's very commonly used by
but amitriptyline is a big no-no for geriatrician. We already listed that. If you check Beer's criteria and other advanced country guideline, is advised against to use in elderly. It will cause confusion, it will cause fall. So amitriptyline not good. So you got better option. If let's say patient got a neuropathic pain, you can use gabapentin, pregabalin, which is lesser risk. So we got better new medicines already. And for depression patients, we got better new medicine, escitalopram and all this, less risk. So you need to update your management in these specific conditions. And benzodiazepine, sleeping pills, also another thing quite commonly abused in elderly. So all the benzodiazepine, high risk of fall, high risk of confusions.
So this benzodiazepine is like Stilnox, right?
Stilnox is not benzo, but it's similar as benzo.
Benzodiazepine.
The aprazolam,
like
midazolam,
Xanax.
lorazepam, yes, Xanax.
Okay, because you see, these patients, they have sleeping problems a lot of times.
Yes, yes.
On top of that, because they have sleeping problems, the whole family can't sleep.
Betul.
So, sometimes they come, and these people, they come
They
very
beg for sleeping pills.
Yes, they beg for sleeping pills. They come and see me now, not because they want the blood pressure medicine or they are now want to sleep. So I really am stuck,
Yeah. So insomnia also another big topic. Next time we can share.
Okay.
So insomnia, basically we need to assess why first. Is it primary insomnia or secondary insomnia? Then only we approach. Then got pharmaco and non-pharmacotherapy also. Okay. Next. Next. Okay, driving assessment, to make it short, you just refer to occupational therapists, they will assess. So they have the simulator or the live driving assessment. Then they will certify whether patient fit or not fit for driving. So this is Malaysian. In overseas, different countries have different law. For example, when I work in Ireland, I trained in Ireland before for my geriatric medicines. Once you diagnose dementia, automatically we will refer to the driving authority. They will have the assessment for the person with dementia. So they will reissue the driving license, either it valid for 6 months or 1 year, then reassessment, then reassessment. As the disease progress, then if the patient not fit to drive, then they will revoke the driving license. This is overseas. Malaysia, we don't have a clear law, but occupational therapy say refer to them, they will assess. Okay. So those patients, dementia still insist for driving, please refer. Okay, next. Towards the end, really, future. What are the future? The future thing not in the CPG. Because CPG, we based on the evidence in the past 10 years. So
Yes.
we started the CPG preparation in 2019. So evidence a bit outdated. So what is new? So for the cognitive assessment in the future, we are moving towards digital cognitive assessment tool already. So now everyone know how to use handphone, even all the machi after the COVID pandemic, good training, they know how to press on the phone, right?
Yes.
Yes. So
Cannot live without the phone, actually.
yes, a lot of them playing phone games, watching YouTube and Facebook already. So we are moving towards digital cognitive assessment. And we notice that the rate of decline, the rate of the cognitive decline over the years give us more meaning than the cutoff point. So in the future, we will go towards the rate of the decline. Because everyone start with different cognitive status. Your baseline cognitive status is different. So for example, your IQ test is like your IQ test. Different people is the baseline is different. So you cannot use a cutoff point to determine who is dementia, who is not. It's the rate of the decline. We got the normal aging rate of decline and the not normal aging rate of decline. So this study shows us that this is the normal aging one. This is the amyloid negative. This is amyloid negative. This is the amyloid positive, but not symptoms one. And then this is the MCI with amyloid positive one. They will progress even faster. Yeah. So with the rate of decline, even before they become dementia, we know already they are at risk. So this is the future change coming soon, not yet. Treatment, now we got the specific targeted disease modifying drug for Alzheimer's disease. We target on the amyloid. So for Alzheimer's disease, we know it is because of the amyloid plaque and of course the tau protein. So now they are targeted into the amyloid plaque. So monoclonal antibodies, so far we got 3 in the market, 2 in the market. One is pending FDA approval. So aducanumab, lecanemab, and donanemab soon coming. Okay, so in Malaysia, so far, none of the medicine is available in Malaysia yet. I heard lecanemab is coming soon next year. Okay,
Oh, I
but
see.
yeah, but is Malaysia ready to start this treatment or not? So for your information, to start this targeted amyloid treatment, we must make sure the patient have amyloid because not all dementia is caused by Alzheimer, remember? Some is Parkinson, some is Lewy body, some is vascular. So we must make sure it is amyloid, then we need an amyloid scan. Whole Malaysia, we don't have amyloid scan at the moment. Private, university, government, none. That's why we are not included in the drug trial. So we don't have amyloid. So Sunway is fighting to buy the first amyloid scan in Malaysia, to be the first one to provide amyloid scan in Malaysia.
Because
so let's
the geriatrician is doing a PhD
see in dementia.
dementia.
Then others like biomarkers, previously is CSF biomarkers because too troublesome, now it's evolved, become blood biomarkers. So you take a blood, we can know you have amyloid or no amyloid diseases. Okay, but these blood biomarkers until this moment, they cannot give us the disease burden. So only the amyloid scan can tell us the disease burden. Yeah. Okay, so in the future, maybe it can, we are not sure, they're still in the process of fine-tuning the blood biomarkers. Then with this monoclonal antibody, the side effect is what we are worrying most is the ARIA, means the amyloid-related imaging abnormality. After treatment, about for aducanumab, after treatment, about 30% of them, they have microhemorrhages after the
I
treatment.
see.
We can find MRI. So during the treatment of 18 months, it didn't show any significant worsening of cognitive functions, but we are not sure after 5 years and 10 years. So this is something still not sure yet. But overall, compare these monoclonal antibody treatments with the standard treatments, then of course it is better.
It is better.
It means the decline is still decline, but decline slower.
Okay.
It's still decline. Yeah, it's still decline. But it shows that the amyloid is clear. The amyloid burden in the scan is reduced significantly
So
after the treatment.
it's
So
never
this,
cured one, huh?
yeah, it's never cured. So this one will be in the future lah. I think the treatment for dementia, it will be like a cancer like that. You give treatment to clear the amyloid, then okay, amyloid clear already, your cognitive status is stable, then you are in remission, then but we scan you regularly. If the amyloid accumulate again, you are symptomatic, then we give you a treatment again.
See.
This is what I postulate, I'm not sure. Because until now, the study only 18 months. After 18 months, how? Continue, not continue, no one know.
Yeah, because it's
It's a new treatment.
I suspect the best treatment maybe is
Prevention.
euthanasia. Sorry, I sound very bad here, but for me, I think for me personally, I would. Okay, never mind.
Yeah, but Malaysia is not legal
Yes.
yet. Yeah. Okay. So next, the best treatment actually is prevention. So the question is, can we really prevent dementia? These three people, are you familiar with them?
Of course.
So they are the leaders of the countries. And also they have one similarity. Three of them, they also have dementia. So all these smart people, they also have dementia. How about us? Are we at risk of dementia? So
we
I
also
remember.
smart, right? Who said we're not smart?
Yeah, they are smart really. We also at risk. So one of
Okay.
my professor, he said, as long as you have a brain, you are at risk of dementia.
Oh my God. That is
If you live long enough, you are at risk of dementia, as long as you have a brain. So next time, if you want to scold people brainless, then you don't scold people brainless. You say, congratulations, you don't have risk of dementia. This is the joke, the prof tell me.
God, that's so
Congratulations, you don't have risk of dementia. Means you are brainless. Okay.
okay.
So the correct word to use is actually risk reduction. We can't really prevent a dementia. So it's a risk reduction measures to reduce the risk. So if you read the CPG, then there are long list of risk factors. So to summarize it, it's a cardiovascular risk factors, physical inactivity means sedentary lifestyles, and also social isolation. So the risk reduction measure is opposite of the risk factors. Means do more exercise, physical activity, stop smoking, nutrition, healthy balanced diet, then stop the alcohol, cognitive intervention, social activity, weight management, severe risk factors control, manage the depression, manage the hearing loss. Hearing loss is a risk factor for dementia. So if your patient have hearing loss, encourage them to get hearing aid. Yeah, don't leave it. It will increase risk of dementia.
Oh.
Okay.
Okay.
How about supplement? A lot of people asking, any evidence, any supplements can reduce risk of dementia? So at the moment, after we review the CPG and the guideline, everything, no strong evidence. Yeah. So I don't really recommend, but healthy balanced diet and do all this, we call it multi-component interventions. Exercise, social activities, cognitive stimulation activity, learn new things, keep your brain active. Yeah, don't say after retire, you stop working totally. Then your brain will deteriorate very fast. Okay, come to the last. I think I'm on time. Take home message. So number one is cognitive assessment is to support your diagnosis, to monitor the patient's progress. Don't preoccupy with the cutoff point. Okay, so if the patient have cognitive complaints, but with normal cognitive assessment score, so patient, for example, a retired CEO come and see you, then they say memory issues, but your MMSE normal, very good of 26 or 28. Please refer to a specialist for further assessment. Because MMSE may be too easy for them. You need a higher level kind of cognitive assessment test. So rule out other dementia mimicking conditions. Then acute cognitive decline is always delirium until proven otherwise. Non-pharmacal treatment is the mainstay now for the management of dementia. Do no harm, avoid the inappropriate medicine that I mentioned just now. Okay, so if you forget everything, at least you learn about the anticholinergic burden drugs. Don't use all these medicines in dementia patient. Okay, that's all my sharing today. Thank you for your attention. Any questions? Got 5 minutes
Oh, a
for
lot of
questions.
questions.
Ah,
Very good. I really enjoyed your talk. Okay. Unfortunately, I have one problem. I
mm,
have a brain, so I'm at risk of dementia. But we have a lot of questions, mainly from Doquity. And
mm,
Dr. QSN asks, what are the facilities that a dependent can use? Okay. Can
dependent can
use. What's the
dependent?
facility can use to fully utilize the geriatric medical services provided by the government hospital, and which hospital?
Okay, so which government hospital have geriatricians? Okay.
Not
Not
only
every
geriatrician, but she's talking about facilities. I'm not sure what
facilities.
facility she's talking
What
about.
do you mean?
Maybe we don't have
Dependent.
daycare, right?
Government hospital at the moment, no. Most of the daycare run by NGOs, a lot of dementia society. Each state we have dementia society, and then some of them they have their NGOs to run the daycare for dementia. So
Okay.
for example, in KL, ADFM, Alzheimer Disease Foundation Malaysia, they have daycare. Then the Genting, they work together with they have a dementia daycare. Then some private nursing home, they have daycare also. But government hospital so far at the moment, not yet.
Okay. How many geriatricians do we have and in the government sector?
In the whole country, 60 plus. In the government sectors, about 30 plus, almost 40 already. There are new geriatricians graduating every year.
I tell you, these geriatricians are becoming so popular. Nobody can get appointment with geriatrician these days.
Yeah.
Even my friend was telling me it's impossible. Okay.
waiting appointment for new case is 1 year.
Oh my
My waiting appointment is 1 month now.
Your
Not too
waiting
bad,
appointment is 1 month. Okay, where can we download this CPG?
Academic Medicine of Malaysia.
Okay.
ACAMED.
Okay, GP from Doquity asks, are there differences between the diabetic dementia, the geriatric and senile dementia and Alzheimer's in terms of clinical presentation? That's a very nice, good question.
Okay. I am not sure what do you mean by senile dementia. There's no such a word, senile dementia.
Okay.
So Alzheimer disease and what?
And let's say cardiovascular.
Vascular. Okay,
let's say
vascular dementia.
basically in your many type of dementia, patients presenting, is there a difference? Like, for example, some tend
Yes.
to be more forgetful, some tend to
Yeah.
be more aggressive.
Yeah. Okay. This is not for all, but the common pattern pattern for Alzheimer disease, they will present with forgetfulness first, memory issue first. Yeah. And behavioral issues, suspicious, saying people stealing their things, behavioral change. These are Alzheimer's. Vascular dementia depends where is the infarct. So if let's say the infarct at the frontal lobe, they have behavioral change first. Yeah. If the infarct at the temporal lobe, then maybe they have a language understanding problem first. So it depends where is the infarct. And then for vascular dementia, most of the time, if you ask family members, they can pinpoint to you when the onset. So for Alzheimer's disease, it's insidious onset. When you started the symptoms, they said, not sure, maybe 2 years, 3 years. We also not sure, but they are sure it's progressively worsening. But for vascular dementia, it onset, but it's quite persistent one. Until they have a neck stroke, then it deteriorates. Then quite persistent until they have a neck stroke. So we call it stepwise deterioration for vascular dementia. So from history, you roughly know, because the family can tell you, or after how many months, then it become need help for bathing already. Then after how many months, can't really talk. So they can have a stepwise story for you. So Alzheimer's is gradual one. Can't really tell you when and when.
Okay, question for between BADL and AIDL, there's ways, I think you have already covered that in ways to decrease the progression. Okay, number 5, how strong is the evidence of first generation antihistamine consumption causing dementia? I think that one is not that it causes dementia, but it worsens.
Increased risk.
Yeah, increase the risk. of
increase the
patients
risk.
who already had dementia.
Mm.
Okay, question 6, if dementia is not treatable, what is the primary aim of treatment?
Is to delay the progress of the disease to give better quality of life, so that the person with dementia, they can maintain independence as long as possible. This is the aim of the treatment.
Okay, what is your opinion of a demented parent staying alone? For the safety reason, the children decided that the demented parent is to be rotated 3 monthly, staying with them so that better care can be given. Will this rotation staying with the children 3 monthly worsen the? That's a very good question, because we want to share out, we can't take the risk, we can't take the stress also. So you have so many
So
children.
most of the time, I will analyze the situation with the family, then they decide themselves the pro and the cons of each decisions. So for person with dementia, if you rotate them frequently, they have difficulty to adapt to new environment. So for example, in son number 1, the house is like this, setting like this, the toilet is here, the kitchen is here. Okay, so move to the daughter house. The daughter house, the toilet is different place. So they might confuse, where is the toilet? Then they don't know where to find the toilet to pee. Then they pee on the floor. Then it causes the behavioral issues. Then they feel ashamed. Then they got the emotional issues. Yeah. So change of environment may have problem of adaptations. So you must take this into consideration.
Okay.
So leave it alone. If let's say early stage of dementia, the patient still can call, still can communicate. If they want to live alone, then maybe can, but you need to check on them regularly, especially those on medicines. For example, those on diabetic medicines, high blood pressure medicines. You must check on them so that they don't overdose or they forget to take their medicines. And then some, they will put CCTV to monitor for early stage. But for moderate stage and above, they need help in their activity of daily living. So they cannot be left alone already.
Okay. Now, question 8 is in an individual with dementia and Parkinson's disease, what is dysphagia most likely due to?
Dysphagia.
Yes.
Difficulty in swallowing.
Yes.
Okay. So dementia, as the disease progress towards the end of life, they have dysphagia, difficulty in swallowing. Parkinson's disease also. Parkinson's disease, as the disease progress, they also have dysphagia. So all this because of neurodegenerative disease. So Parkinson's disease also one of the neurodegenerative disease, because the neuron all die already. So the swallowing also will be affected. It's one of the autonomic functions. Yeah.
Okay. Okay, is there any role of you using donepezil? We already covered that. In postural hypertension, advice for ABC. What does the B stand for?
The bed position.
Yes. Okay. Dr. Mary Ann asked, is there a lab test that we can detect dementia?
At the moment, no. Dementia is still a clinical diagnosis.
Okay.
History, physical examination, your cognitive assessment, fulfill criteria, then you diagnose. So it's a clinical diagnosis.
Okay. Dr. Dayalan, which cognitive assessment tool is sufficient to be used for GPs?
Okay, for GPs, Minicog, AMTS, these two is sufficient.
Okay. So Dr. Macario asked what medicine to avoid that mix. And then we have covered that, and we have also shown you the link to the website where you can also check your medicine. Yeah.
CPG, we have the whole list. You can read the CPG also.
Yeah, but we can check easily because
easily,
every room has computer now. Okay, so same. Any criteria in determining which type of A cell to finish first in view of? I don't understand this question. What type of A cell to start first in view of that is, or which would you prefer? Would you prefer to start on rivastigmine or donepezil?
Okay. Okay. We are calling extract inhibitor, rivastigmine or donepezil. Which type to start first?
Yes.
For me, both also the same.
No, both also the same.
Both also the same. Either one will do.
There's no head-on comparison with any randomized trial?
I think no head-to-head comparison.
Just
but
with
the endpoint is almost similar.
Okay. I myself feel like it is a very, very sad disease because recently I myself witnessed a colleague having this disease. It was really very
Devastating.
devastating. I met this colleague and he couldn't remember me. And every 5 steps he asked me, can you bring me to the ward, this ward? I was so irritated, at first. Yeah, it was really sad. Very, very sad.
Yeah. And as we going to aging population, then the dementia person population will be getting more and
But
more.
my friend who is the colleague is only 2 years old, 3 years older than me. Yeah.
Now you start to worry already.
Oh, I worry lah. I got a
I'm
brain.
also worried. That's why I study. That's why I study PhD.
You study the more brain cells you have, the more damage it might. Okay lah. The more you study, the more you learn. It's okay. So there is some more question coming, Dr.
Yeah.
Tay.
Yeah.
She's Dr. Tay, not Dr. Tan. Sorry, because I put. Do you have any elderly patients who are referred for worsening dementia after GA? And do you have any
Yes.
statistic or guideline?
GA, sometimes it will cause the dementia to deteriorate faster. Like what I said, any acute event, admissions, the graph will drop. So most of the time, because of delirium after the GA or the acute event.
Yeah. Sorry.
So
Okay,
after, if let's say this happen, we need to do rehabilitation.
Okay.
Okay.
We have to stop now. My dog wants to come in. Okay. So anyway, I find this quite interesting. We'll stop the live stream now. Okay, thank you very much. This is very interesting. I am not a person who's very interested in dementia or the elderly and too chronic a disease, and worse is deteriorating all the time. There's no option of treatment. Whereas in cardiology, you just come in sick, a lot of action, we treat you, you go home well. So, but I find this very interesting and I hope that there is a cure for it. And I definitely would like to bring you back for further talk next year.
Yep.
Yeah.
If let's say a new treatment, then we can share again.
No, there's so many things to talk about. I don't know yet, but yeah, it's because the population of elderly is growing so fast, and it's a huge population now. And geriatric, 20 years ago, who have ever heard of geriatrician? Now everybody is looking for geriatrician.
I'm leading the fashion.
Yeah. My friends all messaging me, where can I find geriatrician? Where can I find? Can you recommend us a geriatrician? And every time they say, I can't get an appointment. Okay then. Thank you very much.